So good evening. So this is a topic which you probably won't get in exam, but for me and my trainees, this is a regular topic in their exam. They get one in their written exam or in their OSCE, and it is coming. It is coming in more and more in every aspect of medicine. So, and I was looking at doing something related to rehab, but unfortunately, there is not a lot of literature specific to rehab. So I thought I'll talk about generally. And why it is important is that now I consider myself a very privileged as a doctor, and you all. The reason is that a lot of people come to us and we do a lot of things medications, surgery, injections. And in real world, some of them are mutilating and or assault. If you go to the law, they are assault. But people will come and they happily receive the treatment. So it is very important for us to make sure that we provide utmost care and look at our patients, provide them the outcome which they require, and improve their lives. So that's why I'm interested in this topic. And you would have I don't know whether any of you have seen these TV series. This comes in different names. The reason me showing this, if you really interested, I would like you to watch one or two series. It actually talks about how an incident is investigated, come up with conclusions, and how those conclusions are used in improving the airline safety. And airline flying in a flight is a very dangerous thing because once something happens, nobody can save you. But very rarely accidents happen because they have learned from accidents and they improve their system, they improve their processes, and it's a very process driven. Now, previously people used to sort of compare hospital with airline. Hospitals are a very dangerous place. So many things happen. It's a very dangerous place. But people used to compare hospitals with airlines. But airlines is a lot of linear processes, but hospitals are almost like nuclear reactors, where things happen regularly, but there are systems and checks to make sure that small things, small errors, it doesn't become a big error. Now, the reason for me showing two flights here, one is A380 and one is A320. One has got about 400 seats, one has got about 300 seats. Now, it is estimated that the number of patients dying or significantly disabled from a medical error every day is equal to 2 of these crashing every day. And the other reason is that Qantas is the only airline which has not lost a jet in their entire life. So every other airline has lost jet from accidents. But the most important thing is think about these two flights falling from the sky. Just think about once a month, two of these falling there. There'll be a lot of investigation. But unfortunately, a lot of patients dying every day. Nobody is actually looking at it. There are people looking at it. We'll come to it in a minute. Now, there are a lot of sort of incidents here of these are all from UK, US, and Australia. I tried to look at some of the Indian ones, but I couldn't find any. These are well investigated. Bristol one, Mid Staffordshire NHS lost the NHS chair, lost the job. Even the hospital changed the name. Dr. Death is a fellow in Australia who actually killed a lot of people doing surgery. Nurse Lucy Letby killed a lot of newborns recently. Libby Sion is somebody, is an interesting situation where somebody who's taking a MAO inhibitor, antidepressant, come to the hospital, get a pethidine injection, develop possibly malignant hypothermia and dies. The interesting thing was Libby's father was a very well-known attorney, so he actually pressed charges and created a lot of things, and that actually resulted in most of the U.S. hospitals reducing the work hours of their junior residents. Betsy Lehman is another interesting thing. This happened in Harvard Medical School, so Dana-Farber Cancer Center. This is a lady who's a well-known press person from Boston Globe, and husband works in the cancer center, get 4 times the dose of chemotherapy and dies. Willie King lost the opposite leg. It's a well-investigated story. Josie King is a 18-month-old baby who died in Johns Hopkins, and they settled the case with Johns Hopkins starting a Center for Patient Safety. And Prudy Pharma, everybody know, Mundi Pharma, and the opioid crisis in the US. So these are certain incidents which actually bring this patient safety more and more. Now, it all started with 1991 when a Harvard medical practice study which shows that 3.7 in events per 100 admission, 27.3% caused by negligence, 16% causes death and permanent disability. There are a lot of studies happening in other countries, similar one. We all know that we should not do any harm. There are a lot of numbers here, people dying from medical errors. Errors happen in outpatient setting. 50% of the harms are preventable. And it's all end up in actually 1999, Institute of Medicine come up with this paper that to error is human, suggesting that approximately 40,000 American dies with medical error every year, possibly double the number actually. Then it's followed by another paper in about 10 years later, which actually shows that nothing has changed much. What are the common causes of patient harm? I'll bring this slide again later. Medication errors, surgical errors, wrong side surgery, healthcare-associated infection, sepsis, not recognizing sepsis, it's a very common thing. Diagnostic errors, patient falls. I mean, we are not looking at stopping the falls. We are trying to reduce the falls, making sure that the appropriate action is taken if the patient had fallen. Venous thromboembolism, treating, preventing. Pressure ulcers, we had a lot of discussion about pressure ulcers. Unsafe transfusion practices, again happens. Patient misidentification, wrong patient, wrong surgery, wrong site surgery. Unsafe injection practices, not following the infection control processes. What are the factors? A lot of system factors. I mean, I look at things from a system point of view. I don't consider as an individual as a problem here. The system makes the individual to do wrong things. So system and organization factors, wrong infrastructure, overwork people. Technological factor, we bring a lot of technology into healthcare now. The failure of the technology. Technologies are not appropriately vetted. Human factors, overwork people. Some people, some behaviors are bad. Some people are actually, they always want to do wrong things, or otherwise called cowboy behaviors in Texas. Patient-related factors, some people unfortunately get complication after complication. Nobody knows why. External factors, some of the reasons we don't really know why they are getting problems. Now, WHO has recognized that September 17, 3 days back, as a World Patient Safety Day, and this year they were talking about diagnosis. So get it right, make it safe was their slogan. Looking at right care, right place, right time and cause, avoiding the adverse outcomes, and making appropriate clinical decisions. So I always consider appropriate patient care from 3 pillars. So safety pillar, safety always comes from airlines. So airline is, so healthcare takes a lot of safety knowledge from the airline industry. Quality comes from Toyota and those type of factory that you heard of, Lean, Sigma, and all those things. And experience of the patient as well as the staff, which is something which we don't do a lot, but we are looking at doing a bit of work in actually bringing the patient and staff experience and see how you can actually improve the quality of care. Now, when you look at the error, there are certain errors preventable. Certain errors are not preventable at all. I mean, medication-related adverse effect, not always preventable. Some of them we know. The patient had an adverse effect before, we should avoid giving the same medication. But you see, patient had a penicillin allergy, getting penicillin again and dying. That need to be prevented. Act of commission and act of omission. Act of commission is doing something wrong. Act of omission is not doing something right. Slip, lapses, and mistakes. Slips and lapses are just error in action, they call. Slips is that you really have not done as a specific part of the task. Lapses are memory lapses, you miss doing a part. Or mistakes are you have done something appropriately, but that was not the right thing. Giving a wrong medication is a real mistake in healthcare. When you look at the safety event, you look at a sentinel event where the patient, there's a significant injury to the patient, including death. Or near miss, there wasn't something happened, but somebody could identify that and stop it from happening so that patient didn't die or patient didn't have an adverse event. Latent failure is some of those things which has been sitting around, not causing any problem, it's just waiting, an accident waiting to happen. Like most of the things we consider as the structural issues, or overwork people, lack of staffing, and all those things. Negligence, you all know, something purposefully doing something wrong. Now, this is one of the old models of safety, like Swiss model. It actually looks at the linear model. There are a lot of latent things happening, and then an active failure happened, everything flowed through, and an incident happened. But we don't really consider this nowadays because we know that none of these things are linear. There are multiple things happening at the same time. Not one thing, two things causes an error in a hospital, because the hospitals usually have a lot of steps to prevent an error, but sometimes everything fails. Now, one of the most important things where a failure happens in a hospital is communication. Now, communication with the patient. I mean, I looked at a lot of patient complaints, and 90% of the time, what they mention is communication. That person didn't communicate with me this. So we don't really communicate with the patient. I mean, there are a lot of videos you would have seen. Orthopedic surgeon goes to the patient and say, your leg is going to be amputated tomorrow. So that sort of communication we do. We don't really tell them what is real the story is and what are the next steps. And then other issue is communicating among ourselves. How do we communicate? We don't communicate. We don't a doctor to another doctor, a doctor to nurse, a doctor to somebody else. The communication is poor. There are a lot of things you can do actually to improve communication. You can have a huddle. You can get together. You can get a group of people talking about a patient. Nurses do in some time when they hand over. They do a huddle. You can actually brief. You can debrief after an event. You can use something like a ISBAR format. Identify the situation, background, assessment, and recommendation. So we encourage a lot of our juniors to actually write case notes like in that model so that it's very clear. Closed loop communication, so we communicate something and that person sort of tell us what they understood from that communication. This is other thing which our trainees get involved with, that how when something happened to a patient, an adverse event happened, you have a right, you have a responsibility to tell the patient what happened and apologize for that. When we apologize, we don't really consider that we are actually taking the responsibility, but we are just telling the patient what has happened here and what we are going to do in terms of investigating an appropriate action. A lot of time, we are very fearful that end up in having a compensation claim or something. A lot of time, what my experience is that patients are very grateful. If you tell them the story, what really happened, they're happy with that. This is sort of a open disclosure framework which we uses. So we actually acknowledge report the incident, review, manage and finalize, and then feedback to the people involved. Other thing is root cause analysis. So we see a lot of symptoms. We really have to figure out what is the cause of that. And you can actually look at multiple causes, analyze what the cause is. Sometimes you use a fish diagram. So cause, sort of bring that cause, sort of divide that cause into multiple smaller sub-causes, and then identify what the problem is. So the steps are defining the problem, identifying the factors, what's the root cause, and then corrective action. And once you had an action, then evaluate that. Now, patient safety system, which I said about identifying the issues, corrective action, making sure that you have ongoing monitoring to make sure that the system you put in are effective. Speaking of safety is one of my interesting topic, where we actually wanted something we call a safety culture. What we realized that when you work in an environment where people feel safe, the errors are less, the quality is better. So we wanted to make sure that any of our staff are able to raise an issue. They are not blamed when. So, for example, a nurse says in a theater, a nurse says that we are missing a sponge. Even if that it is, when you count it again, we are not missing anything, we should not be blaming that nurse because they have actually raised an issue. So that's where, so making sure that there is no blame. And always, if you can achieve that, the quality of care is really better. Now, I was looking at what is this national safety implementation, and only topic I could find an article. It talks about talks about certain things, but I'm not really sure what has gone beyond that. I know there is an accreditation body, but I don't know it's mandated yet, the accreditation for hospitals. Now, I showed you this slide before. What do you do differently now? You're the person who actually matters. If you look at the hospital environment, you're the person who is highly paid, and you're the person who can influence. So all these errors, all these harm-related events, we can actually do something, and we can make the life better. Now I move to quality now. So these are two interesting sentences. Or every system is perfectly designed to get the result it gets. We actually need to know what we do, and then we do the best. Now, domains of quality, we look at safe, effective, patient-centered, timely, efficient, and equitable care. How do you do quality improvement? Already looked at, Dr. Goyal was talking about KPIs and outcomes and all those things. We do clinical audit, evidence-based practice, clinical standards, workforce planning, benchmarking our centers with other centers. And then if we actually see a poor performance, we actually need to handle the performance. Not to blame a person, to see whether we can actually retrain that person, retrain that group of people, and then improve their performance. Now, we always look at changing the healthcare. It is very difficult to change something in healthcare because we always say traditionally we did like this. There's a significant power imbalance. A lot of time nurses don't feel talking to the doctors, so they're not bothered. Hierarchy. I'm the boss. I will do what I feel like. Silos. We always wanted to be like, oh, I'm the best. We also have a lot of tribalism. Neurologist doesn't like rehab. Rehab doesn't like somebody else. So we all have our own ways of doing things. Now, you always look at how do you change. This quarter's 8-point change. It's like we always look at having why you want to change, get a group of people, work around it, communicate the vision, and then build on that change. Now, this is the part I really wanted to concentrate on, quality improvement project. So these are actually quite good if some PGs wanted to do some research topic, quite easy to do. And a lot of these are publishable in journals, so it's something which is pretty good. So systematic effort to identify, analyze, and address areas of improvement in patient safety. It can be, can look at the current system issues, a new improvement, an audit, feedback from patients, complaints, consumers, all those things can be used to develop a quality improvement project. Now, the most important thing, the first step is that what is the issue here? When you really look at a quality improvement project, identify a problem. And first of all, if you can identify a problem in care or delivery, it could be process or outcome, then you look at, is that a problem for a bigger group of people? You identify a problem, is it a problem for a group, is it a problem for the hospital? And do you have a data to demonstrate there is a problem? Like your outcomes are pretty poor, your length of stay is long, or something else, you get more infection in your ward, all your surgical patients has got more infection than other group of people. So if you have got data to support that. Then you look at the process mapping, so end-to-end process mapping. I mean, we do look at this process when patient comes in, do something, and they go home. We look at how that patient, what are the steps involved in that process, and how many diagnostic steps were there, how many decision-making steps were there, how many bottlenecks were there. So we can actually look at all those things. And you can look at the variation. So why a group of people has got bad outcomes, and the similar, if you go somewhere else, they have good outcome. And there are centers there are places where they do a particular particular surgery or something, do very well, very little complications, but not the same situation with other people. So we can actually look at why that variation is. Then we can actually look at brainstorming the ideas to see where is the problem and what are the possible solutions. Anybody can actually, if you've got a group of people, anybody can give us an opinion. We always look at that 5 whys. We ask the question, why 5 times. Most of the time we get an answer. And that's what Socrates used when he used to teach his disciples. He kept on asking the question. You get an answer, he asks the question again. So it's asking that question, why again, will actually get to the bottom of the problem. Then once you have a solution, you actually divide that solution into whether it's a high impact solution or a low impact solution, whether it's easy to implement the solution or difficult to implement solution. You always wanted to look at easy to implement and high impact solutions, and then try to actually identify those solutions. Then go into a PDSA cycle or any improvement cycle. You can actually talk about a lot of things. PDSA is one of the technique, but you can use lean, you can use sigma, you can use lean sigma, all those things. All talking about different things, but the same thing ultimately. So you can do a PDSA cycle, and at the end of PDSA cycle, you look at a small change, and then you use that another PDSA cycle. So it goes on cycles and cycles. So when you do a PDSA cycle, it's a plan, do, study, and act. So you look at 3 things. What are we trying to accomplish? So what are our SMART goals here? And what are our measurements we are going to use? And what will actually make an improvement, and how we can sustain that improvement? There are the 3 questions you ask. So in a plan phase, you actually look at the improvement goals, and then plan the cycle, who is going to do, what they are going to do, and then gather the evidences. Then in do phase, carry out the plan, document any issues, gather data. In study phase, analyze the data and compare the data with what our predictions are, what our previous data is, and then you sort of examine what are the learnings. And then you decide, in an act phase, you decide whether you wanted to actually abandon that because the benefits were not very good, or then you abandon that. If benefits were good, then you actually can maintain that, sustain that, and then move from there. So it's like sometimes you have to do multiple steps to actually see what the improvement is. So it's actually quite easy to do if you are a if PGs want to do a project, and it's a quite impactful but relatively easy to do. So that's from me at this stage. Any questions? Any comments? Mostly welcome.
Any queries from the resident side?
Thank you.
Just a frivolous comment. Why is your name Kochiyil and your home is in Calicut? That's number one. What are all those?
You have asked this question 2 times before.
Then in your introductory slide, you had your name and then a whole lot of letters following that.
Yeah.
What does that mean anyway? It was not even Greek and Latin to me.
Which one are you talking about?
Your introductory slide.
Huh?
Your introductory slide, the first one.
Oh my God. You want me to explain that? So I have the qualification in rehab and pain. I have a qualification in hospital administration. I have an executive MBA. I have a master's in clinical service operations.